Today we are to talk about the ST elevation MI or STEMI as it is very famously known. Or in the past it was used to be known as the transmural MI. But I would rather call it a monster MI or the monster heart attack because it comes and it devastates the patient within the fraction of the seconds or the minutes. I can recall a patient who visited, who was brought to our ICU from the emergency department, and he was 45 years old patient, had a chest pain complaint, and we did the ECG, and ECG was actually done in the ER department. There were ST elevation changes in the inferior leads, 2, 3 and AVF. Patient, while we were talking to the patient and staff, we have a very good ICU team there. While the patient was being started the treatment and staff was taking the IV line, immediately patient start having grunting sounds and patient just got knocked down. So when we felt the carotid, there was no carotid. We immediately started the CPR with the ACLS protocol, and after 10 minutes into the CPR, and we twice used the defibrillator because there were VFib and the VTEC during this whole ACLS process. In just 10 minutes, again patient started talking to us, and patient was smiling and as if nothing has had happened. So in those 10 minutes, it felt as if some monster has attacked the patient and was kicked away. So I would rather call it ST elevation MI or the monster heart attack. So this is such an important diagnosis. So let's talk about the ST elevation MI. So let's talk about ST elevation MI. ST elevation MI is a very important part of the acute coronary syndrome. Now, we have already discussed that ACS or acute coronary syndrome comprises of three entities. One is unstable angina, one is non-ST elevation MI, non-ST elevation MI. In the past, it used to be known as subendocardial MI. Subendocardial MI. And the last one is ST elevation MI. So these three are the entities of the acute coronary syndrome. This acute coronary syndrome comprises of unstable angina, non-ST elevation MI and ST elevation MI. We also call ST elevation MI, in the past it was called transmural MI. So one of the very important concept of the MI, unstable angina and STEMI, is that in both unstable angina and non-ST elevation MI, this coronary artery has got a partial blockage. This has got a partial blockage. If I make a thrombus here, this is the thrombus. So it partially occludes the coronary artery. Now when there is a increased demand or the supply of the blood falls below a critical threshold, then patient starts having the complaint of chest pain and starts developing certain ECG changes, which we discussed would be T-wave inversions and ST depression. And this is what's the problem over there, that there is a thrombus formation which is partially occluding the flow of the blood, but some blood is flowing across this thrombus. But in case of the ST elevation MI, remember one very important point. If this is a coronary artery, which is supplying to the muscle of the heart. In case of the ST elevation MI, it is completely occluded by the thrombus. It's completely occluded by the thrombus. So at this time, no blood will flow across the thrombus, across this obstruction, and it's a disaster. It's the complete shutdown of the supply of the blood, its oxygen, its nutrients to the myocardium. So myocardium is in danger of being dead after a certain period of time. So in cases of the ST elevation MI, the thrombus completely occludes the coronary arteries. We can take the analogy of a traffic jam. If there is some sort of obstruction in the traffic flow, but a part of the road is actually open, the chances are people will not be as anxious, angry and upset as they will be in case of a complete traffic jam. If the road has completely been shut down and the traffic is standing over there and the persons who are waiting at their homes and offices, everything will be quite upset and disastrous. So in case of the ST elevation, it's a complete blockage of the coronary artery and it puts the myocardium at risk of being dead. But in cases of both the unstable angina and non-ST elevation MI, there was some sort of flow across the thrombus. It wasn't fully occluding, or it was not completely blocking the flow of the blood across this coronary artery. So this is a major difference, one very important difference. And as I already discussed, it's a part of acute coronary syndrome. So how many coronary arteries we have in our cardiac system? There are 3 coronary arteries. Let me draw them and let me make a diagram that which part of the myocardium or heart they supply. So these are 2 atrias. These are 2 ventricle. This is septum. This is interatrial. This is interventricular septum. Just outside of the aortic valve, there are 3 coronary arteries. This is right coronary artery, RCA. This one is a right coronary artery. This is right side of the heart. This is right side of the heart. This is left side of the heart. Now, this artery is known as right coronary artery, or famously known as RCA, right coronary artery, or RCA. Which part of the heart this right coronary artery supplies? It supplies right atrium, this one, right atrium. It supplies right ventricle. It supplies inferior wall of the heart, which is placed on the diaphragm. Inferior wall. Number 4, it supplies 60% of the time, it supplies SA node, sinoatrial node, 60% of the time, and 85 to 90% of the time it also supplies AV node. 85 to 90% of time it also supplies AV node, and it also supplies part of the septum. What are the names of its branches? RCA has got 2 branches. One is posterior descending artery, and a right marginal branch. Right marginal branch or artery. So when we talk about the coronary arteries, the one which is coming from the towards the right side, Actually, coronary arteries, they branch off from just outside of the aortic valve, and the blood goes into the coronary arteries during the diastole, not during the systole. The right coronary artery, it supplies inferior wall, right atrium, right ventricle. 60% of the time it supplies SA node, 85 to 90% of the time it also supplies AV node, and it also supplies part of the septum. And this right coronary artery has got two major branches. One is the posterior descending artery and one is the right marginal branch. And in majority of this patient, the patient's right coronary artery is the dominant artery, meaning by it supplies the posterior descending artery. Then comes the another very important. This is a left main stem. This one is known as left main stem. This is a left main stem. This is again very important part because sometimes thrombus lodges here. Left main stem. Then this left main stem divides into two more branches. One of them is left circumflex artery. Left circumflex artery. This is the, why we call it left circumflex? Because it takes an acute turn towards the left side. This is a LCX, left circumflex artery, and it supplies this lateral wall. It supplies lateral wall of the heart, and in 40% of the patient it also supplies SA node. So along with the right coronary artery, there is an other artery which we call left circumflex. Why we call it left circumflex? Because it takes an acute turns on the left, lateral side or left side, LCX. And which part of the heart it supplies? It supplies lateral wall, and 40% of the time it also supplies SA node. Now what is the third branch? Third branch is, which originates from the left main stem, is a left anterior descending artery. This is left anterior descending artery. Left anterior descending artery, or LDA. LAD, left anterior descending artery, LAD, and it also gives off a diagonal branch. So left anterior descending artery comes from the left main stem along with the left circumflex branch, and it supplies anterior wall of the heart, anterior part of the especially left ventricle. So coronary arteries are three: right coronary artery, left main stem divides into the left circumflex artery, and left anterior descending artery. Left anterior descending artery gives off a diagonal branch, and it supplies the anterior part of the left ventricle. The lateral part is supplied by the left circumflex, which in 40% of the times also supplies SA node. Now the right coronary artery supplies right atrium, right ventricle, 60% of the time SA node, 40 and 85 to 95% of the time AV node, inferior wall, and part of the septum. So this is the coronary circulation of the heart. But now the question arises, what was wrong with these coronary arteries that the person had to come to the hospital and had certain of the complaints, underwent certain tests, especially the ECG, and had to undergo specific management. What was wrong? What was the main issue with these coronary arteries? We already discussed that the coronary artery is completely occluded. By the thrombus. Okay, is completely occluded by the thrombus, and this thrombus is not letting the blood flow across it, and the myocardium on the receiving end is in risk of being dead, or it may die if this issue is not dealt properly. Now the question arises, if we have a 20 years old boy or a 15 years old boy and a 60 years old person who's got some problems in his life of the medical perspective, so have they got the same coronary arteries? No. There are certain risk factors which cause the development of this atheroma within the coronary artery. This may be lying in the coronary artery, or it would may have come some from other part of the circulation. But this process is known as atherosclerosis, which causes the formation of this clot in the coronary artery or some other artery. That is known as atherosclerosis. And there are certain risk factors of development of the atherosclerosis. Why this atheroma is formed? There are certain risk factors which puts a person at the risk of developing this atheroma in the coronary circulation. What are those risk factors? There are two types of the risk factors. One group is modifiable risk factor. Let's talk about them. Modifiable risk factor. There are three major modifiable risk factors. One is gender. Second, age. And third is family history. Now, why we are talking about these risk factors? Because these are the one which are present in those patients who develop atherosclerosis in their circulation, and one day either that atheroma present in the coronary artery becomes so mature, or it just ruptures and causes the complete occlusion on some distant area of the coronary artery where it is narrow, or from some other place this embolus is coming after breaking off from the atheroma and causes the complete occlusion of the coronary artery, then which leads to the ST elevation MI. So these are the risk factors which cause that atherosclerosis to actually happen. One is the gender. Male are more prone to develop cardiac issue, ST elevation MI, atherosclerosis as compared to the females. But this story goes as long as the female is not postmenopausal. In the postmenopausal female patient, the chances of developing cardiac problem are as equal as they are in the male gender. But those female who in the pre-menopausal stage are using estrogen, they are also at risk of developing cardiac issues and atherosclerosis. So male are more prone to develop cardiac problem or atherosclerosis. Age, as we age, we run into the risk of developing the atherosclerosis and consequent ST elevation MI or cardiac problems. So younger patients have less issues, have less risk of developing cardiac problem, and the older one have got a higher risk. But we cannot change our gender and age. And then comes the family history. Those families in which there are male members who have developed cardiac problems in their 40s and 50s, and females who have developed their cardiac issues around 55, they are more vulnerable to develop atherosclerosis and cardiac problem. Again, we cannot change the family history. So there are three non-modifiable. These are this is not a modified, but these are non-modifiable risk factors. A category is non-modifiable risk factor. These are non-modifiable risk factor. We cannot modify them. We cannot change them. So these are non-modifiable risk factor. Gender, age and family history are the one which when someone is having these problem, like if one is getting older, you cannot modify it. That is why we call it non-modifiable. And you cannot change your gender, you cannot change the family history. So non-modifiable risk factor are the one which cannot be changed, because if these are present in any person, like if there is a 20 years old person, he's less susceptible to develop cardiac issue as compared to the one who's 65 or 70 years old. Male are more prone to develop cardiac issue as compared to the female, and those people who have got a very strong family history. And when we talk about the strong family history, that means the male members developing cardiac issue around 45 to 50, and the female member developing cardiac problems around 55 years of age. So this group was non-modifiable. Now we will talk about the modifiable risk factor. Modifiable risk factor are the one which we can change actually. So modifiable risk factor are the one which we can change, and modifiable risk factor help to reduce the risk of cardiac problem once they are engaged properly. What are those modifiable risk factors? Diabetes mellitus, hypertension, smoking, hypercholesterolemia, obesity, BMI more than 35, sedentary lifestyle, stressful or type A personality. D, okay, D, this is D and this is F. And type A personality or stressful personality. Or stressful personality. Okay. So the second group of the risk factor which a patient if has and has got a derangement of these problems will be more vulnerable to develop cardiac problems. These are diabetes mellitus. If not properly controlled, a poor control of the hypertension will put some person at a high risk of developing cardiac problems. Smoking is one of the very important modifiable risk factor. Quitting smoking helps to decrease the risk of developing a cardiac problem. Taking a very good control of the cholesterol, this is hypercholesterolemia. If we put patient on the statin, if we ask the patient to go for a proper dietary control of the cholesterol, that will help. Obesity, if the body mass index is more than 35, then patient has a higher risk of developing cardiac problems. So obesity is a modifiable risk factor. Then comes the sedentary lifestyle. You can actually group these together, obesity and the sedentary lifestyle. A person who has a risk of developing cardiac problem should be advised an exercise routine, like 3 times a week, a brisk walk of at least 20 minutes, aerobic exercises. One should be advised to lose weight, because losing weight, quitting smoking, and taking good control of diabetes and hypertension, and being very careful about intake of the fat. Polyunsaturated fats should be taken, and the diet should contain fruits and the vegetables. So that would help to manage cholesterol level properly. Then sedentary lifestyle. The new corporate sector people, they are most of the time working 9 to 5, and when they come back to their homes, they are not able to go out for the exercises and walk. So all the time they are sitting in their offices. It helps to actually increase the risk of developing MI, because they become obese. They are not good at control of diabetes and hypertension, and even their cholesterol level is higher, so that puts them in the category of metabolic syndrome. And nowadays there is a much talk about the metabolic syndrome, because if someone is obese, is having a sedentary lifestyle, and either diabetic or hypertension tensive or both, is has got a more risk of dying at the hands of the myocardial infarction than as compared to those who haven't got this problem. So then comes the type A personality, or the stressful personality, because these patients most of the time they have adrenaline rush, and there is a higher sympathetic or adrenergic activity, and they are tachycardic because of some already atheroma in their coronary artery. When the demand goes high at any time, they become very vulnerable to the for the development of the ST elevation MI. So these are modifiable risk factors which can be modified, which can be managed. If a person gives a good control to all of these, then patient can have a better control over the risk reduction of the development of the MI. So now the question arises, how these patients present in the emergency department. When a person has developed a trauma in the coronary arteries, and at one day either an ambulance comes from somewhere else and causes the complete obstruction of the coronary artery, or the thrombus has completely occluded the coronary artery, then what are the complaints with which the patient is coming to the hospital? Just imagine the myocardium, which was receiving blood, nutrients and oxygen from that coronary artery, is now completely occluded and is devoid of these circulations and nutrition and oxygen. It turns to the anaerobic oxidation, causes the formation of ATP, which goes into the, then adenosine and endorphins are released, and nerve endings, they are stimulated. So patient starts feeling severe pain, chest heaviness. So in the clinical presentation, how these patients come to the ER. Most important thing is chest heaviness. Chest heaviness. Trying to imagine that this coronary artery is completely occluded, and the person who's coming to visit your ER or ICU is the one who's having a coronary artery completely occluded with this thrombus. So imagine it first and then look at what are the presentation of that patient. There would be chest heaviness. Patient will describe as if something is sitting on the chest. Patient will be making a fist sign, Levine sign. Patient will not be finger pointing the pain. Levine sign is the one where patient will tell that I have got a pain here, will be making a fist. Our patient will be telling you that I have got a chest heaviness, as if an elephant or something is sitting on my chest. Patient has got chest heaviness, Levine sign or the fist sign. Patient may complain of retrosternal heaviness. Retrosternal heaviness. Patient may have profuse sweating. Profuse sweating. And patient may have nausea and vomiting. Nausea and vomiting. And patient may have pain epigastrium. Pain epigastrium. So chest heaviness or severe chest pain, So the symptoms a patient has when the patient is visiting the emergency department or ICU are the complaints of chest heaviness. There can be severe chest pain which the patient describes with the help of a fist that I am feeling pain here. It may be associated with profuse sweating, irritability. In case of the involvement of the inferior wall MI, patient may be nauseous and vomiting. Patient may have a pain epigastrium and there can be retrosternal heaviness. This pain can be radiating to the jaw, left arm or towards the back. So these are the clinical presentation of the patient. One very important point which we should always remember in case of ST elevation MI, because look at this complete blockage. In case of the ST elevation MI, the best person, the most important person who knows that he has got a cardiac problem is the patient himself, because on the patient face you can see a fear of impending doom, as if the patient knows the fact that he is about to die, because he has sensed the problem. This is such a grave and severe problem that you can look at the fear of impending doom on the patient face. Fear of impending doom. So patient can have a fear of impending doom, and just by looking at the face of the patient you can actually know what's going on. This is a fear of impending doom. But if after developing ST elevation MI, because it's a most major heart attack, patient can go into the pulmonary edema, in that case patient will be presenting with shortness of breath. Patient will be coming with tachypnea, dyspnea. There would be difficulty in taking breath, and once you check the chest by auscultation, you will feel crackles are on the both side of the chest. Patient may present in the cardiogenic shock right after ST elevation MI, because it's a monster attack. Patient can present in the cardiogenic shock, can come with the heart failure. There can be extreme sweating, and there can be irritability, chest heaviness, because coronary artery is completely occluded by the thrombus. So this is the presentation of a patient of ST elevation MI. Now, how these patients actually, when they present in the ER, how is their ECG? What we find in their ECG, as the name implies, that we should find an ST elevation. But we should never forget that there is a complete blockage of the coronary artery. So, we will find an ST elevation. So, what is the normal ECG? When we see here, this is P wave. First downward deflection is Q. Then comes the upward deflection of R. Then comes the second downward deflection of S. Then is the T wave. So this is Q, R, S. This is a physiological Q wave, and this is T wave, and this is isoelectric line. Then comes the P wave once more. So this point where S wave actually joins a straight line between S and T is known as J point. Junctional point are the J point. J point is that point in the normal ECG where the second downward deflection, which we know as S wave, it is joining this straight line which connects it with the T wave, and this point is known as J point, which is actually at the level of the isoelectric line normally. But what happens in ST elevation MI, that this J point goes high, it goes here and draws T and S along with it. This is what we call ST elevation. So let's draw it here. How the ST elevation or the convex ST elevation will look like. This is again PE wave, a physiological Q, and R, S. This is normal, but here what happens, that J point, the junctional point, instead of coming down here, it draws actually both the T and the S up, and this is known as ST elevation. J point has brought the T and S upward. It can be like this. It may have different morphology, but the central point is that there has been elevation of the J point along with T and S. This is known as ST elevation. ST elevation. And whenever you see that there is ST elevation in any ECG, whenever you see there is ST elevation in the ECG and patient came with the chest heaviness or the chest pain, the first thing which should come to your mind is that the coronary artery is completely occluded with the thrombus. There are certain differential diagnoses, but in a patient who's coming with severe chest pain, profuse sweating, has got risk factor, and the ECG shows that there is ST elevation as compared to the normal. Try to compare these two. This is normal P, Q, R, S and T. But this is ST elevation MI. Then the thing which should come to your mind is that the coronary artery is completely occluded with the thrombus. And this is the ECG diagnosis of the disease, which is ST elevation MI, because if this thrombus is not dealt with, the myocardium which is on the receiving end will die within 1 to 2 hours. So you do not have the privilege of getting cardiac enzyme in 4 to 6 hours. Forget about the cardiac enzyme during the initial management. This is an ECG diagnosis, and immediately you should start thinking that what should be the plan to manage it, because it's an ECG diagnosis. You cannot wait for the cardiac enzyme, because cardiac enzyme are supposed to be positive or negative in 4 to 6 hours. If you are going to wait for the 4 to 6 hours, you will lose the option of managing these patients, because the coronary arteries are completely occluded with the thrombus. So this is an ECG diagnosis of the patient. So now the question arises, how we can say this is anterior wall ST elevation MI, this is inferior wall ST elevation MI, this is lateral wall ST elevation MI. We will see which set of the ECG leads have got this change of the ST elevation. We have 3 sets of the ECG leads. If I draw the diagram of the heart again, so this is heart, this is inferior wall of the heart, this is lateral wall of the heart, and this is anterior wall of the heart. And if I draw the Einthoven's triangle, in Einthoven's triangle, this is Einthoven's triangle. Einthoven's triangle. In Einthoven's triangle, lead 1 is located here, AVL is located here, and they are looking at this part of the heart, which is the lateral wall, especially the upper part of the lateral wall. So 1 and AVL are known as 1 plus AVL are known as lateral wall. Lateral wall ECG leads. So a change of ST elevation MI, a change of ST elevation in lead 1 and AVL will be lateral wall ST elevation. We will call it, the patient is having lateral wall ST elevation because ST elevation is in the lead 1 and AVL, which are looking at the lateral wall. Lead 2 is located here, Lead 3 is located here and AVF is located here. Lead 2, 3 and AVF are looking at the inferior wall. So these are inferior wall limb leads. Lead 2, 3 and AVF. These are inferior wall leads. And these are known as contiguous leads. 2, 3 and AVF are contiguous, 1 and AVL are contiguous. So at least 2 of these leads should have that change in the ECG which we call ST elevation to label this patient as having inferior wall ST elevation MI, because lead 2, 3 and AVF are looking at the inferior wall of the heart. So this is inferior wall, these are lateral wall. Now let's talk about the anterior wall. We had seen that in the chest we have V1, V2, V3, V4, V5 and V6. So if there is any change in at least 2 of the chest leads, V1 plus V2 plus V3 plus V4 plus V5 plus V6, they are looking in the transverse plane of the anterior wall. These are known as anterior wall leads and they are contagious lead. They are contagious lead. So any change of ST elevation in at least 2 of these contagious leads will tell us that the patient has anterior wall ST elevation MI, because these leads are watching the anterior wall in a transverse plane. But if you can actually focus that lead V1 and V2, they are located towards the septum, so these are known as V1 and V2 are known as anteroseptal. Anteroseptal. So if there is a change of ST elevation in lead V1 and V2, we will call as anteroseptal ST elevation MI. Lead V5 and V6 are looking at the lower part of the lateral side of the anterior wall. So V5 and V6 are known as anterolateral leads. Anterolateral leads. So a change of ST elevation in V5 and V6 will be called as the anterolateral ST elevation MI. And the lastly V3 and V4, they are purely anterior leads. So V3 and V4, if they have got ST elevation, it would be called pure anterior ST elevation MI. Anterior STEMI or ST elevation MI. So just by looking at the position of the ECGs and finding a change of ST elevation and knowing that the coronary artery which is supplying these respective wall has got a thrombus which is completely occluding the circulation to the myocardium, will give them the name of the wall, whether this is lateral wall ST elevation MI, inferior wall ST elevation MI, anteroseptal ST elevation MI, anterior wall ST elevation MI or anterolateral ST elevation MI. Another very important concept, if you can actually remember, 1 and AVL, they are looking at the upper part of the lateral wall especially, and V5 and V6 are looking at the lower part of the lateral wall of the anterior wall. So whenever you find a change in V1 and AVL, chances are that the same change can be in V5 and V6. So the lateral wall is purely actually washed by all these 4, especially 1 AVL, V5 and V6 leads. Now let's talk about the management of these patients once they have been diagnosed with ST elevation MI and we are sure of the diagnosis. And can we get the cardiac enzyme? No, we haven't got enough time, because we cannot wait for 4 to 6 hours, because cardiac enzymes, they take 4 to 6 hours to be detectable in the blood, and here in case of the ST elevation MI, we haven't got this much time because the myocardium will die. there is a very famous phrase which we call minutes are the myocardium. Here the minutes matter, not the hours actually. So can we go in the management plan, can we go to the MONA issue? No, we haven't got that much time. MONA needs some time, but this patient has no time. A patient of ST elevation has no time. Patient has a very limited time to manage the patient, so we will not go to that option. Now, the management starts from one very important realization, whether the hospital where patient has been actually received has got any facility of the catheterization or not. A, there can be no catheterization facility, or the one which we can shift to is at a distance of more than like 2 to 6 hours. So we will actually go for the B option, that where if there is no catheterization option, we will pharmacologically manage the patient. So let's talk about a situation where the catheterization facility either is not available or is available at a distance of more than 4 to 6 hours, and we know the patient will not make there, so we go towards the pharmacological option. And here we are not talking about that about the medications which will stop the growth of the thrombus, because the thrombus has already completely occluded the coronary arteries. Here we are talking about the medicines which will actually break away the thrombus. Where we are talking about a silver bullet, the one which will destroy the thrombus, will recanalize the coronary artery. So here we are talking about thrombolysis, fibrinolysis. So the medical management of the ST elevation starts with the, if we say this is a medical management, we need a clot buster, because what was the problem? The coronary artery is completely occluded with the thrombus, and we need a medication which can break it away, which can lyse it, which can just cut it into pieces and recanalize the coronary artery. So we need fibrinolysis. We do the fibrinolysis with the help of medicines, also known as thrombolysis. We want to break the thrombus, so we need a medications which can actually break the thrombus. Here in Pakistan we very oftenly use streptokinase. Streptokinase is a fibrinolysis drug, is a clot buster, and it comes in a strength of 150,000 unit, and we dilute it in 100 ml normal saline, 100 ml normal saline, that is streptokinase. Streptokinase. This is a non-specific, non-fibrin specific. It can break clot anywhere in the body. It's a cheaper injection, but first we need to rule out, before we give fibrinolysis, we need to rule out if there is any contraindication to it. What can be the contraindication? There can be any subarachnoid hemorrhage, brain hematoma, there can be any space occupying lesion, a pre-surgery within the last month or within the 3 months, any CPR more than 10 minutes. These are pregnancy is a relative contraindication, and there can be ongoing bleeding problem is a contraindication of giving the fibrinolysin. So if there is no contraindication, we will give streptokinase. It's a cheaper injection, and it's a almost 1.5 million unit. 1.5 million unit. We dilute it in 100 ml normal saline, and we slowly infuse it to the patient. It takes us around like 45 minutes or 1 hour, 30 minutes to 60 minutes to infuse this injection. Because it causes hypotension, so we are to be very watchful about the blood pressure of the patient. If the blood pressure drops, then we are to stop the streptokinase. It's not the costly one. It's not as costlier as other options. So in Pakistan, we use so oftenly this SK injection, streptokinase. Now, within how much time we need to give, we need to start streptokinase, or we need to start thrombolysis? Within 1 hour of the presentation of the patient to the hospital. Say, for example, this is a hospital door. Patient comes to the ER, and it should take only 10 minutes for the ER people to get the ECG of a patient who came with a chest pain. And within the next 10 minutes, this ECG should be analyzed by a cardiologist or any person who's good enough to actually diagnose ST elevation MI in consultation with the cardiology people. In next 10 minutes, it is diagnosed, and in the next 10 to 20 minutes, patient should be shifted to a place where cardiac monitoring is being done, and patient is given this injection of streptokinase through the needle. We give the injection through the needle. So it was a door, and we started it with the help of needle. So this is known as door to needle time. Door to needle time. What is door to needle time? Door to needle time is the time which a patient once when enters the hospital, and when the patient has been started with this injection through the IV line or the needle, is known as door to needle time. If we want to get the best result from the fibrinolysin injection, then it should be door to needle time should be less than 60 minutes for the best and the optimum result. Door to needle time should be less than 60 minutes. 60 minutes. So just to recap how we give streptokinase. Streptokinase is a 1.5 million unit injection. It is diluted in the 100 ml normal saline, and this is slowly infused over 30 to 60 minutes. And door to needle time, which is the time when the patient enters the hospital and the time when patient started with streptokinase through IV line, door to needle time should be less than 60 minutes for the optimum result. So this is a cheaper injection, but clot non-specific, has got very much allergic reaction. You need to first rule out whether you give this one or the costlier one. You need to rule out the contraindication of giving thrombolytics, because it will thrombolize, it will break this clot, and it will re-establish the flow of the coronary blood through this coronary artery. So this is known as fibrinolysis or thrombolysis, or the medical management of ST elevation MI. What is the second option other than the streptokinase? Other than the streptokinase, we have a costlier injection which is genetically engineered. It's a genetically bioengineered injection we call LT-Place, or this is a tissue plasminogen activator. Tissue plasminogen activator. Though there are examples of Reti-Place, Tenecti-Place, but one very favored and very much used, though it's a costlier one, is LT-Place. LT-Place is a clot buster. It breaks the clot. It's a tissue plasminogen activator. It's genetically engineered. And how we give it to the patient, this is either a 50 milligram injection, it's a 50 milligram and 100 milligram injections. So we give it 15 milligram IV bolus. We give 15 milligram IV stat straight away, and then we give 0.7 milligram per kilogram body weight in the next 30 minutes. 0.7 milligram per kilogram in next 30 minutes, and then we give last dose of 0.5 milligram per kilogram in next 60 minutes. In next 60 minutes. So this is a costlier injection. It is not much used in the poor countries like ours. We go for the streptokinase, but this injection, which is a altiplase, is a tissue plasminogen activator. It's a genetically engineered injection. Comes in the strength of 50 milligram and 100 milligram. We give 15 milligram IV bolus stat. Mind it, there should be no contraindication to the fibrinolysis. There should be no bleeding diathesis, no previous CPR, no recent surgery, no major head trauma, no space occupying lesion, no subarachnoid hemorrhage, no brain intracranial hemorrhage. You need to rule out these contraindication, and pregnancy is a relative contraindication. You give 15 milligram IV stat, then you give 0.75 milligram per kilogram body weight in the next 30 minutes, and then you give 0.5 milligram per kilogram in the next 60 minutes. So this is how we give the tissue plasminogen activator altiplase. And door to needle time here as well should be less than 60 minutes for the optimum result. So once we have given these injection to the patient, how we will know that our injection has been successful? Because it's a blind procedure. We want to break this clot. But the question arises, how we will know? We are not radiographically monitoring patient. So how we will know that by our fibrinolysis or thrombolysis option has been successful? Now, it will be evident from two very important points. First, for example, if this coronary artery thrombus has been broken and the flow of the blood across this thrombus has been re-established. Now, re-established, how we will know? First, there will be resolution of the chest pain. Chest pain will resolve. Resolution of chest pain. B, the height of the ST elevation will decrease by 50%. There will be a 50% decrease in the height of the ST elevation. For example, if initially it was like this, it would come to this now within, okay, say here. So the height has decreased around 50% and the chest pain has settled down. So these two things, if happen within 1 hour or after giving the injection, they will tell us that the injection therapy has been successful. But if there is no resolution of the chest pain and ECG changes haven't settled down 50%, the height of the ST segment hasn't gone down 50%, then we are to go back to the option B, which we will discuss now. We opted for the option A because of two reasons. Either there was no facility of the catheterization lab, so we had no other option, or if the hospital had this facility but there was a huge difference between the cost, then the family opted for the option A. Option A is not as good as the option B because it's a blind thing. It has got certain risk factor involved in it. So anyway, we had to go for the option A, which is medical management or use of the fibrinolysis. So now Now say if the hospital has got the facility of the catheterization and there is a cath lab present, then what will be the management? What are the options there? Okay. If a hospital has a facility of catheterization lab, then we can actually opt the interventional approach to get rid of this thrombus. What is the interventional approach? In interventional approach, what we do, the procedure is explained to the family and the patient, and then we gain an access to the circulation of the heart through the either radial artery, or we can go through the femoral artery. We pass a guide wire all there. Then just looking at the circulation radiographically, we can go all the way up to the aorta, because the coronary arteries, they are located outside of the aortic valve, and then there is a blood flow in the coronary arteries during the diastole. If patient has got no contraindication, especially no kidney problem or no allergic issue, we can give contrast over there, and we can see all these things on the monitor. We can fluoroscopically or radiographically observe the status of the coronary arteries, and when there is a filling defect, we know that this specific coronary artery has got a thrombus, because blood is not flowing across that thrombus, and there is a filling defect. It can be right coronary artery, it can be left anterior descending artery, it can be left circumflex artery, and this whole process is known as angiography. So this is what we do, that if there is a catheterization facility available, we do angiography. As we know the literal meaning of it, angio mean blood vessel and graphy mean picture. Now on the monitor, we actually look at the picture of the coronary arteries, and now we know for sure that this coronary artery, which we had on the ECG paper, some idea about it, because if there were changes in the 2, 3 and AVF, the probability of right coronary artery having the thrombus were high. But in case of the angiography, we know now, through the angiography, we know that which coronary artery has got the problem or which coronary artery has got the thrombus. Now through the same catheter, we can pass another catheter which has got a balloon on its tip. We can move that balloon tipped catheter all the way to the point where the coronary artery has got the thrombus, all the time watching it on the monitor, radiographically monitoring it. Once there, if for example, if this is the balloon tipped catheter, so say this is a catheter, it is got a balloon over there. If this balloon tip catheter goes there, we inflate the balloon and we make the way for the blood to flow through it, and this part of the thrombus is sucked with the help of a suction apparatus along with this catheter. So we repair this blood vessel with the help of a balloon tipped catheter, which we send through the radial artery or the femoral artery, and we monitored it on the screen. So this is known as repair of the blood vessel, angioplasty, because now we have re-established the coronary flow across the thrombus. So this is known as angioplasty. Angio mean blood vessel and plasty mean repair, and we call it balloon angioplasty because the catheter had a balloon on its tip. So this we didn't go for the medical management, but rather we opted for the interventional approach. We went there, we diagnosed through the angiography in the cath lab, then we did the procedure to get rid of this thrombus, and this process is known as repair of the coronary artery with the help of balloon, or we can call it balloon angioplasty. And this process of getting angiography and angioplasty is known as PCI or PCI or percutaneous coronary intervention. This both things together they are known as percutaneous coronary intervention. Percutaneous coronary intervention. And because we primarily decided to go for interventional approach if we had the facility, so that is why it is called primary PCI. We call it primary PCI because it was our primary decision to go for the interventional approach, and this is superior as compared to the drug or the pharmacological option, because here we are continuously monitoring the status of the vessels on the monitor. So this is known as percutaneous coronary intervention, which has a balloon angioplasty. And another very important point, this is the door where the patient entered. This is ER and we got ECG in 10 minutes. So this is the same door through which patient entered to the hospital. Patient had this ECG in 10 minutes. In the next 10 minutes, this ECG strip was actually analyzed by the cardiologist, and decision was made because there is a cath lab available and the family and patient agrees for this option. Then we go for the balloon angioplasty. This time it is known as door to balloon time. Door to balloon time, because we use the balloon to get rid of the thrombus. Balloon time should be less than 1.5 hours. Door to balloon time should be less than 90 minutes for the optimum result to salvage the myocardium from the monster attack. This is door where the patient entered. Within the next 10 minutes, patient should have an ECG. In the next 10 to 15 minutes, it should be analyzed by a cardiologist, and decision regarding the management option should be made, and patient should undergo this procedure, and the time at which it starts should be this door to balloon time, where the patient undergoes balloon angioplasty. Balloon time should be less than 90 minutes. Now there is a risk of restenosis. When we take out this catheter, we take out the balloon, we have got rid of the thrombus, but there are chances that this area is now very sensitized and vulnerable. It can restenose. There can be again a formation of thrombus within a day or two or a week. So in order to avoid that, we put there a stent, which can be a drug-eluting stent. We will place a stent through the same catheter. Now we had this catheter. Now instead of having a balloon on its tip, we will have a metallic stent here. We will take it there, and this stent will be re-expanded over there. So it will keep, it hasn't not only opened the coronary artery, it will keep it patent there. This is known as angioplasty plus stenting. Angioplasty plus stenting, or PCI plus stenting. Why we place stent? Because we want to avoid the reocclusion or again formation of the thrombus at the very point where it is very vulnerable. Why vulnerable? Because we know that in case of the thrombosis, one of the reason is that there is endothelial damage that puts the coronary artery at the risk of again development of the thrombus over there. So we do the stenting. So this is the interventional approach. So this was known as the primary PCI because primarily patient was decided to undergo the PCI. But what happens? But what happens in those patients who actually underwent a pharmacological intervention? They either had streptokinase or alteplase, but it didn't work in them. They still have chest pain. They still have all these problems of like ECG changes. So what's the next option now? Again, we go to the option of the intervention. We do the PCI, we do the percutaneous coronary intervention, which is again angiography and angioplasty. We take the picture of the coronary arteries and then we repair the coronary artery. But here the name of the PCI would be rescue PCI, because we are now trying to rescue the patient. We are now trying to do the damage control, or the we are trying to salvage the myocardium. This time around it is known as rescue PCI. Rescue PCI as opposed to primary PCI. Primary PCI, because in primary PCI we primarily decided to go for percutaneous coronary intervention, but in case of the rescue PCI, the medical management has failed. We gave the injection either streptokinase or altiplase, but neither there was a chest pain resolution, there was no change in the ECG height of the ST segment, so we know that our injection has failed. What's the option left? Again PCI, but now this will be known as rescue PCI. Another very important point, on the angiography, we actually take picture of the heart, coronary arteries of the heart. If I make a diagram here, say this is right coronary artery, this is left mainstem, this is left anterior descending artery, and this is left circumflex artery here. Here it is left circumflex, second branch of the left mainstem. This is left circumflex. Okay, this is RCA, this is LCX, this is LAD, and this is left mainstem. Left mainstem. Now we did angiography to find out which coronary arteries are involved, and say if there is a single disease, like single coronary artery has got a thrombus like RCA or LCX, or these two only branches, then we go for the percutaneous coronary intervention and stenting. But in case, for example, if all of these three coronary artery has got a thrombus, or left mainstem and right coronary artery, they have got a thrombus, what will be the option then? The option will not be the stenting. Then we will go to the cabbage option, coronary artery bypass graft. The option in case of triple vessel disease, TVD, or double vessel disease where two major arteries are involved, either the left mainstem and RCA are involved, the scene would be to go for the coronary artery bypass graft. Coronary artery bypass graft. What are the options in case of a cabbage? In case of a cabbage, what we do, that we take either the saphenous vein graft, from here, or we take internal memory artery or the radial artery. And we do one thing, that if this is aorta and its branches, this is aorta and these are the branches. What we do, that we take either saphenous graft, saphenous vein graft, internal memory artery graft, or radial artery. We stitch one part here and one part here distal to the thrombus. This is how we bypass the thrombus. This is known as coronary artery bypass grafting. And this is what we did with the RCA. We can do same with LCX. This is subclavian artery, and we stitch it across distal to the thrombus here. again we bypassed the thrombus and we have established the circulation of the coronary artery. And in case of LAD, we can do the same. If thrombus is here, we will stitch one part of the graft here in the aorta and second part in the LAD distal to the thrombus. This is known as coronary artery bypass graft. It's a major operation. This is where we open the sternum by the sternotomy. Though there is another option of like with a offbeat option for the bypass graft, but in majority of the cases we do the sternotomy, and it takes like 4 to 6 weeks, for 6 to 8 weeks for the patient to take rest, and there are chances of infection, but all in all the mortality rate is less as compared to the PCI. So the PCI and cabbage are different options which are opted for, like a group of the patient who have got, where we do cabbage in triple vessel disease or two major vessel disease. But in case of a single vessel disease or two minor, we go for the PCI and stenting. So this is a monster heart attack or the ST elevation MI, or this is the most major MI, the one which doesn't give you time. The earlier you diagnose it, the earlier you manage it, the better it becomes for the patient. Because the example I gave in the early, in the start of this video, that patient had inferior wall MI. That inferior wall is being supplied by the RCA. RCA also supplies the SA node and the AV node. So when it had a thrombus, the circulation to those two areas was also compromised. So probably that patient at that very time when he was talking with us, when he was feeling pain, he developed some arrhythmia. Because it was timely managed, patient was present in the ICU, everyone was just standing around the patient, and our ICU has got a very dedicated team of staff. So everyone intervened, everyone did make an effort there. ACLS protocol was implemented. So in 10 minutes, we got the patient back, and this is how it works in ICU departments.